Good afternoon and welcome to our inaugural Journal Club on Case Conversations on Fetal and Neonatal Thrombocytopenia. My name is Kim Roque and I'm Manager of Education at the Foundation for Women and Girls with Blood Disorders. I'll be providing some brief housekeeping notes prior to getting started. I regret to inform you that Dr. Pacheco has had a family emergency and will not be able to join us today. We're very glad to have Dr. Jim Bussel and Dr. Emilie Vander Haar, two of the authors of the article we'll be discussing today, join us. Next slide. The Foundation for Women and Girls with Blood Disorders' mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To that end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Our disclosures for today's program include the following. Next slide. To ensure the best sound quality, during the program, all attendees will be muted. You will have the opportunity to participate in a question and answer session with Dr. Vander Haar and Dr. Bussel at the end of the program. You may submit your questions during or after the presentation portion of the webinar via the chat box in your GoToWebinar control panel located on the right-hand side of your screen, and we'll address them during the Q&A session at the end of today's presentation. The next few slides detail our accreditation process, including our target audience, learning objectives, and non-endorsement statement. In support of improving patient care, this activity has been planned and implemented by CineMed and the Foundation for Women and Girls with Blood Disorders. CME will be provided to physicians and nurses, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME credits for the webinar after its conclusion. For those who wish to refer to this later, we are recording the program and it will be archived on our website. Next slide. We would like to thank Janssen for their support of this inaugural program. Next slide. Before we begin, we have a few questions for the audience. The first question is a quick poll to see how many people are joining us today. Please take a moment to answer the poll question on your screen. Okay. Just a few more seconds. This is a warm-up for doing our next CME question, so please do go ahead and vote and make sure that you feel comfortable clicking the selections. Okay, let's go ahead and close and move to the next poll. We also have 4 pre-test questions. Please take a moment to answer the first question. Okay, just a few more seconds. We will review this material during the webinar. Okay, next question. Okay, go ahead and get your answers in. Just a few more questions or a few more seconds. Okay, great. Next question. Okay, just a few more seconds and terrific. Thank you all for getting your answers in. This is wonderful. Okay, next question. Terrific. You'll note we had a small typo. I apologize, but that was to accommodate space. So thank you for overlooking that. Okay. Just a few more seconds. We have some really exciting material to get through, so we'll speed through these. Thank you all. Just a couple more seconds. Terrific. Thank you. Thank you very much for participating in those poll questions. And now I have the pleasure of introducing Dr. Jim Bussel, who's Emeritus Professor of Pediatrics, Medicine, and Obstetrics and Gynecology at Weill Cornell Medical College in New York. I'm sorry, it should be, apologies, should be just Pediatrics, Emeritus Professor of Pediatrics at Weill Cornell Medical College in New York City. His clinical and research interests have been largely in immune thrombocytopenia and fetal and neonatal alloimmune thrombocytopenia, and he's published over 400 manuscripts primarily in these areas. In the interest of time, I can't fully describe Dr. Bussel's impressive accomplishments, except to say that with his frequent co-author, Dr. Richard Berkowitz, he shared the King Faisal International Prize for Medicine, the so-called Arab Nobel Prize, for their work in non-invasive management of FNAIT. And if you know this area, you will know Dr. Bussel very well already. And we're very pleased to also have Dr. Emilie Vander Haar, his co-author, on this article, join. So thank you both very much for spending your time with us today. And with that, I'd like to turn it over to Dr. Bussel.
Thank you, Kim. I think it's an honor to participate in the webinar and the journal club because of the amazing missions that the Foundation for Women and Girls Bleeding Disorders has been doing. I'm not sure how to get the first slide, so could I ask you to provide it? Okay. We were going to talk about the article by showing discussing a case that was in a family. I'm going to discuss the first generation. Then Dr. Vander Haar will discuss the second generation and review some of the pertinent material. And then I'll come back at the end to talk briefly about FcRn, and then we will be taking questions. So in this case, first, mother unexpectedly had a child born with ICH and severe thrombocytopenia. You may know that given that this was a term child, by far the most common cause of severe thrombocytopenia and of intracranial hemorrhage is fetal and neonatal alloimmune thrombocytopenia, and you already know that's what we're focused on. The testing confirmed it. The second child, our current patient, who will be discussed by Dr. Vander Haar, was unaffected. The third child was affected, and many of you, I believe, will know that currently treatment is with IVIG and steroids in order to not have to do frequent fetal sampling or any fetal sampling because of that, the high risk associated with that. The mother also had a fourth child who was unaffected. Next slide. The genotyping showed that yes, indeed, the mother was HPA-1b1b. The old form of that would be to say she was PLA1 negative. She had strong anti-HPA1A. The good news was that her husband was a heterozygote. You can see that he's 1A, 1B, and therefore that their children would either be HPA-1A, 1B or be HPA-1b, 1B and be unaffected. The alertly did the typing, and our second generation patient that Dr. Vander Haar is going to discuss was HPA-1b, 1B, and therefore obviously at high risk of having cases in her own fetuses and children of fetal and neonatal alloimmune thrombocytopenia. Dr. Vander Haar is an assistant professor at Weill Cornell Medicine in the Department of Obstetrics. She's in charge of the ultrasound unit, and conveniently and coincidentally, she did her fellowship in fetal and maternal fetal medicine at Columbia with Dr. Berkowitz. So the three of us have had an easy time collaborating. Dr. Berkowitz and I have collaborated since 1983. And as you'll see, adding Dr. Vander Haar has just been a total pleasure. So Dr. Vander Haar, why don't you go ahead and talk to us about the next generation here?
Sure, thank you for that lovely introduction. Next slide, please. Or if I have it, I'll take it. Great. So the second generation, as Dr. Bussel mentioned, we were concerned that the daughter, based on her genotyping, was 1B, 1B, and would be at risk for having affected pregnancies. And in fact, when she was referred to us and we retested just to confirm, she was indeed HPA 1B, 1B, and she had at the time no evidence of any circulating HPA 1A antibodies. Genotyping of her husband revealed that he unfortunately was 1A, 1A, and thus any fetus really conceived by the couple would have to obligatorily be 1A, 1B heterozygotes, and thus would be potentially at risk to develop FNAIT. Thus, based on her family history with everything, she was definitely someone who we were concerned would be at high risk for having a severely affected fetus in any future pregnancies. Next slide. Oh, I got it. Good, perfect. So, you know, when you think about management for these patients, really there's not been many patients where we've been able to predict ahead of time who's going to be affected by this. So, you know, there's a number of potential approaches that could be done for a case like this. One would be empiric treatment with IVIG and steroids, something similar to what the patient's mom underwent way back when. The pros of this approach would be protecting the fetus, kind of starting as soon as treatment was started, and this regimen we know is highly effective. However, the cons are that a very strong treatment regimen would likely be required in a case like this where we would suspect a very high risk for fetal intracranial hemorrhage. And then you have more sort of toxicity and tolerability issues for the mom undergoing these treatments. Next thing, perfect. Another option would be just to start monthly anti-HPA-1A antibody testing and then attempt to try to detect development of these antibodies early on and initiate treatment only kind of when it's necessary, as soon as we could sort of possibly diagnose it. And then another, which we will talk about later, is to try some novel approaches. And we'll talk about that more at the end. I won't mention it quite yet, so I'll give the game away. Next slide. So I think the purpose of this webinar, and I think this case sort of neatly segues into our journal article looking at new developments in FNAIT, which was just recently published in the American Journal of Obstetrics and Gynecology. And I think this really does illustrate a number of important principles that I'd like to review in detail. So in this webinar, we're going to describe several new developments kind of at varying stages of their evolution that we believe may kind of to differing degrees potentially revolutionize how FNAIT will be diagnosed and managed in the foreseeable future, including screening, fetal HbA typing, prophylaxis, and FcRn inhibition. So importantly, kind of just to kind of get started with everything, I want to go through screening, because in order to determine who we would want to treat, who would benefit from evaluation, we need to understand how to appropriately screen these patients. The approach to screening is actually somewhat complicated, as some controversy kind of exists regarding the true incidence and severity of this disease, because really up until recently, what we know about FNAIT was based on retrospective studies of clinically identified cases, which found that disease incidence seemed to be somewhere between 1 in 3,000 to 5,000, with a high rate of sensitization in the first pregnancy, up to 60% in these studies, and also a high rate of intracranial hemorrhage, somewhere in the 11 to 21%, 75% of which occurred in utero. And then in these cases where you have, retrospective studies, we found that at birth, the platelet counts tended to be exceptionally low. at least half under 20,000, and more severe in subsequent pregnancies as well. So trying to determine how to screen people based on these like very severe outcomes can become tricky. Next slide. Great. However, recently large population screening studies sort of done in relatively homogeneous European populations show that this disease incidence is actually probably higher than what was seen in just clinically identified cases. They put it as about 1 in 500 to 1 in 1,000. But the first fetus is often not affected. 75% of these cases were actually sensitized at first pregnancy. And the intracranial hemorrhage rate was much lower, about less than 1%. And in these babies, when they were able to identify it, thrombocytopenia was actually much more mild, typically much less concerning. And severity in these cases may not actually increase in subsequent pregnancies. So these numbers give us some hope that a successful screening and prophylaxis strategy could be implemented. However, just because these studies were done in sort of a very homogeneous Northern European population, more information is needed to really understand disease frequency and severity in a US population. However, two sort of major developments have allowed us to move forward with a possible screening protocol, which I'll talk about next. So I think, as you probably noticed from our original initial slides, in order to really screen for which pregnancies would benefit from prophylaxis, maternal HPA-1A1B genotyping needs to be formed at the outset. Based on current literature, we believe in about 1 million pregnancies screened, only 2% of those, or about 20,000, would be expected to be negative for HPA-1A or would be HPA-1B1B, and the remainder would be HPA-1A positive and would not require further screening. Next slide. Just important to note, we are talking about HPA-1A, that first kind of antibody or antigen type, I should say, on this slide, but there are a number of other HPA antigen types out there. They are just by far less common. And so when you're talking about screening protocols, they're not going to be as useful for screening as HPA-1A. You're trying to pick up sort of obviously the largest number of people. So these 2% of women who are HPA-1A negative would then need to be further screened. One of the most kind of important up and coming things that has been looked at is the DRB0101, DRB3, I should say, 0101 HLA antigen. Approximately about 28% of HPA-1A negative women carry this, and this actually identifies an immune response gene without which HPA-1A negative women almost never produce high levels of anti-HPA-1A antibodies. Thus, really the most important second component for screening would be determination of this antigen status in mothers, as well as screening for HPA-1A antibody status to identify women who are already at risk and would need more monitoring than those who are negative. Anyone who would be anti-HPA-1A antibody positive at the outset of screening would need to be referred to a subspecialist for further management of their pregnancy. Next slide. So I want to say, I don't know why my thing didn't show up, just a quick word about DRB30101. That's MHC allele involved in T-cell antigen recognition. The discovery of this HLA antigen DRB30101, an immune response gene, really suggests it is an important component of any FNAIT screening program, as I discussed. So in 2019, Fjellge and Krag et al. Reviewed 4 prospective and 8 retrospective studies investigating the role of DRB30101 in FNAIT secondary to HPA-1A. These studies included more than 150,000 deliveries. These had 3 intracranial hemorrhage and 64 severely thrombocytic neonates, and all of the 64 mothers that were found to have these babies were DRB30101 positive. There were also 214 severely thrombocytopenic children born of HPA-1A alloimmunized women in the retrospective studies, and 205 of those were HLA DRB30101 positive. For just of note, for HLA DRB30101 negative women, the odds ratio for alloimmunization was really low, 0.05, and for severe thrombocytopenia, 0.08, but there were 2 cases of intracranial hemorrhage. So while it is a very good a very good sort of look to see who is at highest risk. There are cases of people developing neonatal thrombocytopenia who are negative for this allele. So I think the kind of most important thing to understand is that this is an immune response gene, kind of without which HPA negative women almost never develop high levels of anti-HPA-1a antibodies. And this is honestly one of the strongest links of a specific antibody response to an immune response gene that is currently known. It is, as I mentioned, extremely rare for an HPA-1a negative woman to become significantly sensitized to her HPA-1a positive fetus in the absence of having this antigen. And thus, as I mentioned, really should be an essential component of any screening program designed to detect cases at like highest risk for developing FNAIT. Next slide. Thus, we would suspect, so once you have these patients at risk for sensitization, they then need to be screened for fetal HPA type. It is important to note that 98% of Caucasians at least are HPA-1a positive, and 75% of those individuals are actually homozygous for those antigens. So not all of the fetuses would necessarily be obligate 1a, 1b for those, because if you have a heterozygous dad, you have some babies that will not be at risk, like this mom. In approximately 25% of cases, as I mentioned, the father will be heterozygous, so 50% of their conceptions will be negative. Sorry for all the math. For the HPA-1a antigen, and that's really not at risk for FNAIT. Thus, although majority of pregnancies will have an HPA-1a positive fetus, 15%, if you do all this math, will not. Thus, you do need to check just to make sure the fetus is truly at risk. I will have you go to the next slide. Thank you. So I think the most important thing is kind of the advances, again, in fetal HPA typing, because as I mentioned, determination of fetal HPA antigen type is really necessary to determine fetal risk. And in the past, previously, there were really only 3 ways to perform fetal platelet antigen typing: obtaining cells from chorionic villus sampling, amniocentesis, or fetal blood sampling, all of which are invasive and do have some associated risks. However, the advent of cell-free fetal DNA has allowed for fetal platelet HPA-1a antigen typing to be done non-invasively as early as 10 weeks. Right now, this testing is available in the United States and Western Europe for HPA-1a, 1b, but not yet for other platelet antigens. It should be available soon, but this is kind of just an important kind of lesson when we're trying to think about how to best screen these patients. And for the purposes of 1a, 1b, it's there and available, which is great. Lastly, I'll mention that there are some screening limitations. So as I mentioned, screening for FNAIT is an important component of preventing FNAIT, because really in the absence of screening, we really only are able to diagnose these pregnancies after the first affected baby. And so typically treatment has been in the past reserved for second pregnancies. But there are still a few limitations to implement to be able to help us really implement a universal screening program. One, the cell-free fetal DNA, while we have the availability to detect HPA-1a, it is limited to a few central laboratories, and there really are no other HPA antigen cell-free fetal DNA screens available. The other is that detection of maternal and paternal platelet antigen really do require special laboratory testing. There's really one centralized place that most of these are sent, which limits the availability of this to be done kind of on a nationwide level. And then more information is still really needed to determine the cost effectiveness of screening, as this could be quite potentially costly, and we want to make sure that it's an appropriate screening intervention. And then the other development that I want to briefly review before Dr. Bussel jumps in with sort of novel treatment approaches is that prophylaxis is something that is also being worked on as well. Next slide. So similar to RhoGAM, a hyperimmune gamma globin that's derived from plasma with prior affected FNAIT pregnancies could presumably provide FNAIT, and one lot of such product is in fact been produced from plasma donations. Go ahead, next slide. Actually, there, perfect. And so there's soon going to be a proof of principle trial to determine if giving that product to non-pregnant HbA1a negative recipients who have been deliberately exposed to HbA1a platelets prevents the recipients from making antibodies to HbA1a. However, there are many uncertainties as to whether NATGAM can actually prevent FNAIT from occurring as effectively as anti-D immunoglobulin does for hemolytic disease of the fetus and newborn. Moreover, even if this NATGAM can be shown to be highly effective in providing prophylaxis in studies of non-pregnant patients, appropriate dosing and a schedule of administration must be determined during actual pregnant gestations. This will require large-scale trials of antepartum testing to demonstrate that an experimentally verified strategy works and that NATGAM is safe for both mother and fetus. So this is a little bit to be seen in the future. Since severe cases of FNAIT caused by HbA1a can not only occur in the first pregnancy but may occur as early as 18 weeks, prophylaxis for those cases would likely need to be started at the beginning of the second trimester and repeated on multiple occasions throughout the pregnancy. So definitely more information is needed to really understand kind of where these go. Okay, and then so I will jump back into the case that you guys all heard about at the beginning. So if you remember, mom, first generation, was 1B1B, had an affected baby, got diagnosed, and then had 3 more babies. And this is her daughter, who we learned about previously, who was 1B1B as well. And we were concerned about her pregnancy being at high risk for alloimmunization. So for this patient, she actually underwent typing for DRB30101 and was actually found to be negative. And just to kind of reassure ourselves that this was not that rare case of, someone having a breakthrough, high risk of antibody alloimmunization, we actually typed the first generation mom and she was positive. So after this, sort of given her history, we felt sort of more reassured about kind of a third management strategy that I want to go through with you. So for this patient, we ended up, despite her being 1B1B and having a 1A positive fetus, we did confirm on her cell-free fetal DNA. We opted not to go straight to treatment because she was DRB30101 negative, and she also, at the time of our evaluation, did not have anti-HbA1a antibodies. Instead of empirically treating her, we followed her throughout the pregnancy with serial sort of 1 to 3 monthly blood tests looking for evidence of development of antibodies. All 5 antibody screens that she had performed between 8 and 37 weeks of gestation were negative for anti-HbA1a antiplatelet antibodies, including one within 2 weeks of delivery and then an additional study we obtained 6 weeks after delivery. The last test, that postpartum test, was performed to ensure that our patient had not become sensitized during her delivery and thereby putting her fetus at risk for any subsequent pregnancies. This patient was allowed to go into spontaneous labor, which happened around 39 weeks. She eventually delivered it by C-section because of routine obstetric indications for failure to progress. And she had a healthy live-born baby, born 9 pounds, 8 ounces with normal APGARs and a platelet count of 250,000, which is amazing.
Thank you very much, Emilie, for doing such a nice job reviewing that. And I just want to talk briefly about inhibition of FcRn. FcRn was first hypothesized in 1964 when it was thought that IgG must be recycled, and was later actually identified with the N standing for neonatal. It's an Fc receptor that's characterized specifically by only binding IgG when in an acid environment and not binding it at physiologic pH. So if you follow the cartoon, starting on the top left, IgG could be entered in a cell. It binds to the thing that looks like a hand with a finger pointing out of it in purple. It binds it there because it's in an acidified endosome. And while it may not look like it, the FcRn is attached to the inside membrane of the endosome. It pulls out the IgG. If you then look to, as you look to your right, you see that whatever antigen the IgG was bound to, or whatever else came in with it, would be degraded by acid. And by the way, the acid environment would also tend to dissociate immune complexes. Meanwhile, the FcRn would recycle the IgG to the cell surface, as you see in the top right. And at that point, because the pH would then be 7.4 or whatever, the IgG would dissociate from it and thus be recycled. So this mechanism was found to not only recycle IgG, but it also is the mechanism by which IgG has been identified to go across the plasma, to go across, the placenta from the mother to the fetus. Next slide. Now, what do we know about the effects of this of inhibiting FcRn? Well, first of all, this has become a very hot topic, and there are at least 4 companies, if not more, that are pursuing clinical trials with antibodies or other molecules that inhibit FcRn. Generally, it's being used in diseases that are thought to be primarily antibody mediated, and studies have been published in ITP, myasthenia gravis, chronic demyelinating inflammatory polyneuropathy, pemphigus vulgaris, and others. There have been, I believe, in myasthenia, phase 3 trials completed, and there are ongoing phase 3 trials in ITP, and 2 phase 2 studies have been published last year. Obviously, I'm only focused on those because that's where my area of expertise is. What does this inhibition do? It lowers IgG levels dramatically because it shortens the IgG half-life, because all of a sudden it's not being recycled. If you want to imagine that we can understand what the mechanisms of the universe are about, you could imagine that the reason to recycle IgG is so that if you had an infection and the IgG molecule cleared a bacteria into a macrophage, you could then imagine that, hey, we would like to recycle that molecule so it could go back out and go attack another bacteria or something like that. Clearly, that's less good when we're looking at a setting where the antibodies are creating a bad effect. Now, the good part about this is that these inhibitors do not change IgM, IgA levels, they don't affect T-cell immunity, and they don't affect de novo antibody formation. So, for example, if you wanted to immunize somebody to COVID currently, if they were on such a molecule, they would still be able to make antibody to it. And then if you stop the inhibition, they would rapidly, presumably have levels, assuming that they would have anyway. Now, FcRn also recycles albumin, and one of the molecules had an issue with affecting albumin more than the other ones, but in general, they all either don't affect albumin or affect it very slightly. Next slide. So it's an obvious target to block IgG transport across the placenta in diseases like HDFN, FNAIT, anti-Ro induced heart block, and others. An advantage here, when Emilie was describing screening and prophylaxis, like with Rh disease, if I can call it that, the prophylaxis is only good there for Rh positive, Rh negative, and much less frequent other cases of HDFN occur despite RhoGAM because you're not prophylaxing for other antigens. The same would be true for the screening process that was outlined, but this would work independent of what the antigen target would be. We believe that the successful use of IVIG to increase the fetal platelet count is primarily because of its effect to block transplacental transfer of anti-HPA-1a antibody. In addition, it also lowers maternal IgG antibody levels in the mom. So you not only are blocking it from crossing the placenta, but there's less of it to go across the placenta. And there have been preliminary trials ongoing in Rh disease, the results of which are not public yet, but would be encouraging if they worked out and would then allow this to be spread to FNAIT. The major drawback is that since normal transfer of IgG to the fetus doesn't occur, if you don't intervene in some way, the neonate will be severely hypogammaglobulinemic and at high risk of sepsis. Interventions either could be stopping the FcRn inhibitor 2 or 3 weeks before the end of the pregnancy, and then giving the mother IVIG so that there would be IgG to cross the placenta, or to plan to give the neonate IVIG right at birth in order to supplement the neonate with IgG antibody. At this point, I think we're going to do the questions again that you were asked before, and then we'll have a Q&A session with Dr. Vander Haar and I.
Terrific. Thank you very much for those terrific presentations. And now you will all see those CME questions up again on your screen. So this is the official post test. If you could respond to these questions, we'll give you a few more seconds to read, think about the content, and to respond to these questions. And as you finish up, if you have questions for Dr. Bussel and Dr. Vander Haar, please do enter those in the Q&A panel on the right of your screen in the GoToWebinar control panel. So just type those and be sure to click submit. Next question. Okay. Thanks to those of you who already answered. Just a few more questions or a few more seconds to get those answers in. And we'll move to the next question. Okay, terrific. Just 2 more and we'll get to your questions. Okay. Just a couple more seconds. I see those answers coming in. Okay, great. There we go. And please wrap up and we'll go ahead and close out those questions. The screenshot in front of you displays how to submit your questions to our 2 panelists. So please enter your questions now and we'll go ahead and read those aloud. Let's see.
Kim, can I?
Rachel? Yes, please. I'm sorry.
That's okay. So Emilie's obviously a great teacher because everybody seemed to know what DRB30101 did in making it more likely of making anti-HPA-1A. To be fair, that would also, if you then made anti-HPA-1A, inhibit platelet production. 2/3 of people recognize that it's no longer considered appropriate to give weekly fetal platelet transfusions in an affected case of FNAIT. And ideally, you would refer to a maternal fetal medicine specialist because if nothing else, I hope this webinar convinced you that there's a lot of developments in the field that may be changing all the time. And in general, you would plan for cesarean section and consider treatment with IVIG or steroids. Most of you did not fall for answering FcRn polymorphisms as one of the appropriate parts of the workup. One of the disappointments has been that there do not seem to be very many of them, so there has not been a way to identify naturally what would happen in that area. So that's the thing you don't need to do, and you do need to do cell-free fetal DNA and DRB3-0101 in addition to typing in antibody detection. I see that we're lucky to have Dr. James with us now. And Andy, I don't know if you want to make any comments or if you want to moderate the Q&A or what you would prefer.
I'd love to start off by asking my own questions. Can you hear me, Dr. Bussel and Dr. Vander Haar?
Yes.
Yep.
Fantastic. That was excellent. And boy, have we come a long way in the last 30 years. Thank you so much, Dr. Bussel, for all the work you and Dr. Berkowitz have done, and now Dr. Vander Haar are doing to upgrade our practice in this area. Practically speaking, how do we order a DRB3-0101? How do we, is that experimental? Is that an orderable test? Does that have to go to a certain laboratory?
Emilie, do you want me to answer that or do you want to?
You're probably the best person to answer that one. You've ordered it.
It's a regularly available test that if you were going to order HLA on somebody, you could check with the lab or the person you would do that ordering with. When we handled this family, it was actually sent as a routine test, not even diversity, Wisconsin, by the managing team at Wash U. So it was, I think it's a routine. That's a routine test. Could I make one comment before you say anything further on Dr. Emilie was too modest to mention that she is the Weill Cornell PI of a trial that's ongoing now, and it was about to start, that will screen approximately 30,000, give or take, women at multiple sites in the US and Western Europe to hopefully set up to do a much larger study, which would explore not only screening, but prophylaxis. And she implied, and I don't know if everybody got this, that other populations may not be, don't have the same incidence of HPA-1A incompatibility and HPA-1A-1B as do Caucasians. So this is an important issue and might lead to further developments in prophylaxis. Sorry, thank you.
Oh, no, that's perfect. And that leads me to the next question, Dr. Vander Haar. Where do we send the cell-free fetal DNA? Or how do we get this cell-free fetal DNA from the laboratory that usually processes it for us to get the HPA antigen typing?
Great question. So there is, Jimmy, you can help me remember the name of this laboratory, but there is one laboratory doing it routinely. When I've had to send it, I basically just ask my genetic counselors, like, which lab is the one that I send it to for this? And they help me navigate it. Okay. For our study, we're having it done centrally, obviously, for study purposes, because it's going to be a multi-site study. I'm trying to, if Jim, if you don't remember off the top of your head, I'll find it for you, Dr. James. I'll let you know.
That is fantastic. And if you would send it to me and Kim, we will send it out to everyone who was on the call. We'll make sure that people have that information so that if they are screening fetuses for their antigen status, they can have access to that. And then I have, Kim, I hope I'm not eclipsing all our other participants who may have questions. Am I, or may I keep going?
Please keep going. We have had a few that have come in. So yes.
Okay.
But please,
Well,
please
my
feel free.
next question then is about the NAIT GAM. Very exciting concept to me. You said that somebody is actually manufacturing it now, has it in development? Are you able to share who that is? I assume it's a plasma company.
Yeah, Emily, maybe I could answer that if it's okay. I think this was started, the work was started by Profilix Pharma on the screening and prophylaxis, and then Rally Bio took over from them. Profilix Pharma collected enough plasma to make one lot just to do proof of principle work. And right now, I think Rally Bio is in the process of working with that to do, as Emily described, looking for what would happen if people are deliberately exposed to mismatched HPA-1a positive platelets. It's not clear at the moment how that's going to proceed, whether they will set up to collect more plasma and make this as a routine, or how it's going to go. And I'm not privy to that to further inform you.
And then, thank you very much. So we'll keep our ears open about that. Then my next question is for Dr. Vander Haar. Dr. Vander Haar, this prospective study that you're doing to identify platelet antigen types in women, I assume early in pregnancy or in anticipation of pregnancy, are you needing more sites? That is frequently what our constituents are asking, is how can they help you achieve your study goals?
I think right now we're still getting a lot of things off the ground. I think right now they do have most of the sites sort of planned out, but as not everyone is ready and going, so as things progress, obviously if we need more, we're happy to reach out to people if they're interested.
One of the things our constituents are very interested is participating, like I said, is participating in that kind of research. And they're interested in knowing what's going on. I will ask him to work with you, with your permission, to get a little blurb about what's happening, and we will be thrilled to post it on our website so that people know in the progress we're making in FNAIT.
Andy, that would there's already should be a blurb on clintrials.gov. I don't know the number offhand, but it should be there.
Well, maybe we could just parasitize that and make sure that what we have is suitable with both of you. Does that sound good?
Sure.
Kim, I hope you're taking notes. And then, Jim, my next question is for you. It's about the role of platelet transfusions in fetal and neonatal alloimmune thrombocytopenia. It doesn't come up very often, but occasionally we've had a woman who has been traumatized or had to receive platelets for some other reason. This isn't anything I've given much thought about. Should we be thinking about that before we transfuse platelets in a childbearing aged woman?
My vote would be that in the rare circumstances where it's needed, it probably should be given. That reflects optimism from two fronts. One, that it's very unlikely that anything would happen. I mean, you're very unlikely to have that be a woman who's HPA-1b/1b, if I understand your question. And then as that is what you're talking about, somebody we know nothing about.
Correct.
So and as
Which
Emilie
just randomly gets platelets.
Right, as Emilie described, if we throw in the DRB3-0101 factor, you're only talking about 1 in 200 who are likely to be sensitized to HPA-1A. And then the other part of the optimism is that I think ideally we'll be better equipped in the future to do something about it in the unlikely event it happens. One of the potential advantages of FcRn treatment during pregnancy is it could be a subcutaneous or IM shot or a very short IV once a week, and nothing like what you have to go through to get IVIG with steroids as we do currently.
Well, that's a nice segue to our next couple questions, which are about FcRn inhibition. Do you know if the this is from our participants, do you know if the FcRn inhibition is being evaluated in patients with hemophilia A and inhibitors?
I don't know. It would certainly be a potentially logical area given that it would be an incomplete reduction.
And then another question from our participants, what would be the dosing of IVIG and frequency in a neonate whose mother received anti-FcRn during pregnancy?
My fantasy would be it would be a one-time thing, unlike other species where, for example, the entire IgG transfer across to the fetus is by breastfeeding after delivery. In humans, it goes all transplacentally, as I'm sure just about everybody on the call knows. So I think it would be a one-time replacement in the newborn of 1 gram per kilo to give a full load of IgG to the newborn.
And then for Dr. Vander Haar, how would you counsel someone who is DRB3-0101 negative?
Great question. So, I think that, as we get these patients enrolled into our study, I'm going to have little spiels for all of these outcomes. But for patients who are DRB3-0101 negative, I would reassure them that places them in sort of our lower risk category for developing a fetus with these problems. I would discuss that there are rare cases where babies have developed intracranial hemorrhage or moms have developed antibodies, and I would recommend screening for anti-HPA-1A antibody formation anyway, but I would reassure them that without that antibody formation, they would be at low risk for developing FNAIT.
Okay.
I'll just mention, Dr. James, I just received an email from our coordinator who's also listening to this presentation, and he mentioned that he is happy to collect names of sites and PIs who might be interested for backup purposes, and they should have something on clinicaltrials.gov soon for the description.
Excellent. Okay, we will be in communication then, and more about that later. And then I think you already answered the next two questions, Dr. Bussel, which is there a role for prednisone and IVIG post-delivery in those who get FcRn inhibitors, and are the antibodies excreted in breast milk? I think you answered that, but if you would just confirm.
Ideally, if they have FcRn inhibition, the newborn would not have any antibodies that has to be dealt with, but obviously nothing in life is perfect. You'd have to check the platelet count and see if anything was needed. I'm pretty sure that in breast milk, IgG4 antibodies are the primarily transferred group, and I'm not sure that the anti-HPA-1A antibodies are in that subclass, but I would suspect there may be a little bit transferred, but not very much. Unlike, by the way, ITP, where it does seem and has been recently shown in a study from Israel that antiplatelet antibodies are transmitted in breast milk.
And our final question is, and either or both of you, although the anti-HP1 or the anti-HPA1 antibodies are the most common, as you pointed out, could you discuss any key learning points about the other antibodies, their epidemiology, their severity, differences in treatment, and just in a quick overview?
Do you want me to do that, or do you want to do that?
You start, and I can step in if there's things that I think you aren't saying. I'm sure you have it.
First, there are at least 33 antigen incompatibilities identified. Mostly they're identified in rare cases where the neonate is severely affected, and then that's why somebody thinks to do a workup and to find it. The most common other severe cases seem to involve HPA-9b, HPA-3A and 3b, and there's some question now whether, because HPA-5b has generally been thought to be milder but is the second most common, whether that there are enough severe cases of that to be important. In East Asian populations, especially, for example, Chinese and Japanese, the HPA-1A, 1B polymorphism doesn't really exist. So they would likely not benefit from this approach unless a different prophylactic agent was developed that would look at HPA-4 incompatibility. That's kind of an incomplete answer to your question, as best I could do it.
Oh, no, I think that was very helpful. I'll just remind our participants, if you have other questions, if you would email them to FWGBD, we can direct them to our speakers if anything comes to mind later. I can't thank our speakers enough for their very comprehensive review of this article. It's nice to hear directly from the authors. And I'll ask the participants if they have any other articles in mind that they would like us to present in this way. Let us know. And then finally, on behalf of the Foundation for Women and Girls with Blood Disorders, I'd like to thank our staff for the work they did to engage the speakers and organize the program. I'd like to thank our sponsors. And Kim Roque, our Director of Education, do you have any last minute housekeeping details I need to share before I close the session?
No, thank you. You all will receive the evaluation shortly, as well as the journal article again for your review. And please do let us know should you have any other questions. And Dr. James, thank you again for stepping in to do such a great job in moderating the questions. And thanks to both of our presenters again.
Oh, thanks again to our presenters. Wonderful. Thank you all. Take care. Bye-bye.
Bye.